time, the state would call Dr. Michelle Cavalier to the stand.
Step forward, please. Raise your right hand. Do you solemnly swear the testimony you're about to give is true and correct, so help you God? Have a seat in the witness chair. Go ahead, Mr. Ness.
Thank you, Your Honor. Good morning.
Good morning.
Could you please state your name for the record?
Yes, my name is Michelle Catelier, M-I-C-H-E-L-E, C-A-T-E-L-L-I-E-R.
And Ms., how are you currently employed?
I am a doctor, a forensic pathologist at the Iowa Office of the State Medical Examiner as an associate medical examiner.
How long have you worked for that organization?
About 13 and a half years.
How did you become a doctor? Just walking through your education.
After college, I had a few years of graduate school and then went to medical school, which is 4 years. Following that, I studied pathology, which is laboratory medicine. That was 5 years of on-the-job training after medical school. Pathology is the branch of medicine that deals with illness or injury. So in the hospital, the pathologist is the person who reviews anything that comes out of anybody, a biopsy, tissue from surgery, etc., and they make the diagnosis. A branch of anatomic pathology, which I just described, is also autopsy pathology. Clinical pathology refers to the laboratory and mostly how fluids are evaluated. The clinical pathologist makes sure that the instrumentation is correct, that the people who work in the lab are qualified, and they also make diagnoses on things like urine or blood. So the training for anatomic and clinical pathology was 5 years. In addition, I had an additional year of forensic pathology, which has to do with evaluating individuals who have died suddenly, unexpectedly, or violently, as well as evaluating injury patterns. That additional year came with the residency years, so there was a total of 6 years on-the-job training, after which I sat for appropriate examinations and became board certified in anatomic, clinical, and forensic pathology.
And not to pry too much into years, but what year did you graduate medical school?
1987.
And you noted some residencies and examinations after. When did you get your certification as a forensic and clinical pathologist?
The anatomic and clinical certification was after the appropriate examinations. I was certified in 1993, and then I passed a separate examination in forensic pathology in 1994.
Now, are there any other certifications since '94 that you've obtained?
There was an option to recertify in those areas, anatomic, clinical, and forensic. It was not necessary, but I did recertify in those areas. And also, I qualified to be a fellow in 2 forensic organizations, the American Academy of Forensic Pathology and the National Association of Medical Examiners.
That recertification, what year did you obtain that?
I can't remember. I think it was 2010, but I'm not positive.
Now, as far as the societies, you went through some of those already. Have you served on any appointments in your capacity as a forensic pathologist?
How do you
I
define
can
this?
rephrase. When it comes to your CV, I was just looking through it. You have a section entitled Appointments and Professional Activities. Of particular interest, if I may be allowed, I was curious, what is a death review team?
That is a board that is appointed. It was required by the legislature. And it is a group of professionals that include pediatricians, medical examiner, people from the educational system, people from transportation, several other groups, and those representatives, total about 25 people, evaluate every child death that occurs in the state of Iowa. The purpose is to evaluate for potential preventable causes of death.
And what years did you serve on that team as a member?
I haven't looked at that for a while either, probably 5 or more years, and I'm currently a member.
As far as any other professional activities, do you teach at all?
Yes, I teach all the time. We have medical students who come into the laboratory on 2 or 4 week rotations, occasionally just a day, and they observe autopsies. And so I teach when I'm doing an autopsy. I teach lectures when we're not in the laboratory. And then I've also spoken numerous times in the community, places that ranged from groups of emergency room doctors to individuals involved in various kinds of death throughout the state, training medical examiners in each county, and wherever I'm asked to speak.
Was there ever a time you served as a medical director?
Yes, I was medical director of the laboratory in a small hospital where I worked for 10 years. So a good part of that time, approximately 8 years, I was medical director of the lab.
As far as forensic pathology, could you walk us through, I know you explained pathology itself, could you walk us through forensic pathology, what it is?
Well, forensic pathology is an area that involves evaluating injuries or deaths as it may be relevant to the public interest. Often that includes deaths that are sudden, unexpected, violent, or unexplained. And those are in order to collect evidence, to document the conditions of death, both by measurement as well as photography, diagrams, and the spoken word. It's also important for identification purposes in some individuals and interpretation of injuries. So ultimately, a forensic pathologist establishes the cause of death and the manner of death and interprets injuries. And all of that is combined with laboratory information, consultants' reports, medical history, scene investigation, any information that would be relevant to the case, and then subsequently an autopsy report is generated, and if necessary, the forensic pathologist also testifies.
As far as autopsies, and I appreciate that this may not be subject to too much specificity, how long have you been conducting autopsies in your career?
Well, essentially, before I went to medical school, or before I graduated from medical school. So during medical school, I visited the coroner's office in Indiana where I trained and performed some autopsies at that time. As a resident in pathology, in my on-the-job training, we had many months of autopsy work. During my fellowship in forensic pathology, I did autopsies every day, essentially, approximately 200 and some in that year. And then when I worked in the hospital, occasionally there would be a necessity to do autopsies on patients who had died. And then in my role as a forensic pathologist, I spend essentially most of my time either performing autopsies, preparing the reports, or teaching about the work.
Have you ever served as a qualified expert in forensic pathology?
Yes.
Have you done so when testifying in court?
Yes.
Your Honor, at this time, I would just tender the witness as an expert in forensic pathology.
No objection, Your Honor.
This witness is recognized as an expert by the court in her field.
Dr. Cavalier, as far as pediatric and asphyxial deaths, have you ever spoken about that subject?
Yes.
And have you ever given presentations on that subject?
Yes.
As far as pediatric, what does that mean in the context of a death in forensic pathology?
Well, by definition, a pediatric death is anyone who dies that's 18 years or younger. That being said, some of the older teens have characteristics more like adults. And so when we talk about pediatric deaths for teaching purposes, we're usually talking about people who are about 13 years or younger, but it varies.
As far as the cases you examine for autopsies, is there an age range you tend to focus on, or what can you tell us about what you experience in your day-to-day as a forensic pathologist carrying out autopsies?
Well, each forensic pathologist in our office, in the Iowa office of the state medical examiner, and there are 4 pathologists, we each take call, and on our call day, we perform autopsies. Generally, most often 2 to 4 cases a day, and we work with whatever case is there that day. So we don't pick and choose the types of cases that we do. I think I have an interest in pediatric cases, but we don't select any cases out for one pathologist.
And when you receive a person for the purpose of autopsy, could you walk us through essentially the procedure of how you begin carrying out your duties as a forensic pathologist?
Yes, well, the first thing is we have a bit of history, and that's very important. We need to know why that person came in, how they died, what the circumstances were, what the questions might be, what their medical history is. As much information as we can get before the autopsy is good, although oftentimes more information is afforded later. When the autopsy itself begins, the body is brought into the laboratory, and usually the body's in a body bag, and that is labeled, hopefully, with the patient's name, and we like for it to be locked, and so documentation of whether the bag is locked and the identifiers are made, and then the body is examined as it appears in the body bag. Sometimes that may be with blood or soiling on it. Sometimes they have clothes on, sometimes they don't. Sometimes they've been tissue donors, and so their clothes have been previously removed. So whatever condition the body is in, we look at it at that time and note possible injuries as well as personal characteristics. After the injuries are initially evaluated and documented, the body is cleansed, and that allows us to see any injuries or identifying marks, etc., more readily. The body is then evaluated in detail externally. So things like eye color and hair color are evaluated, identifying marks, and also injuries. And those injuries are recorded both by photography and diagram and evaluated. And then also, at some point, depending upon the case, when it's most appropriate, evidence is collected. And some cases don't require additional evidence, but some require quite a lot. We take fingernail clippings for people who may have been involved in any kind of physical altercation that we're aware of. We take pulled head hair and sometimes other samples for DNA analysis. We collect things that might be appropriate for a case, such as paint chips or other kinds of trace evidence. Sometimes we have to do a sexual assault kit, as it is done in live people. And so all of the evidence that we see and feel is appropriate on the external body is collected. When all of the external examination is done, or during the course of that, sometimes additional studies are required before the autopsy commences, such as x-rays. Following all that, an internal examination is begun, and that includes the contents of the head, the neck, the chest, and the abdomen, although essentially any part of the body that is relevant to that case can be examined. For instance, sometimes bones have to be sampled if there are fractures. Sometimes we have to look for a bullet wherever it lands. Sometimes we take the spinal cord and the back or the back of the neck is examined. So each case is examined based on the history as we know it and the differential diagnosis, just like any doctor would examine a person on the outside and then determine from the history and the physical findings what further tests might be necessary.
Now, it sounds, you've kind of already noted this, but just to kind of take away some of the part in, but medicalese, I guess. When you receive a body for the purposes of autopsy, do you do every test available to you?
No.
And you were, I think, explaining why that was. Why is that?
Well, again, just like any doctor, we evaluate the history and the physical findings and then determine what tests are necessary. So, for instance, if someone has a sudden death and they're 10 years old and they were playing basketball, then our differential diagnosis is including abnormalities of the brain or the heart. And so if the autopsy appears to be normal, then we might ask for specialists to look at those organs in order to help the family understand what happened to their child. If a person comes in and they've had a pneumonia and a fever, then we might take samples for things like bacteria or viruses. So each case is on its own merit, and just like any doctor, we do the tests that are appropriate as we understand that case.
Now, do you remember coming into contact with a child who named CLOE Chandler, who you did an autopsy of?
Yes.
Do you remember how you were assigned to that case?
I would have just been the pathologist on call for that day when Chloe came up for autopsy.
Do you remember what day you carried out the autopsy of Chloe?
I believe it was July 23rd. Let me just check that. Yes, July 23rd, 2018.
Now, I'll probably walk through the findings and then we'll illustrate them through your photographs, but when you carried out the autopsy of CLOE Chandler, what do you recall the history was that you received prior to autopsy?
The medical examiner sent us a report that this was a 5-year-old child who was found suspended or hanged in her closet where she had apparently been playing.
What medical examiner do you recall providing you this input?
Well, Mark Haggist was the investigator in the county, and he was the one who prepared the report.
Now, was there anyone else present at the carrying out of your autopsy?
Yes.
Who was present?
Well, there were autopsy assistants, and Mary Jo Boyer was my primary assistant, but 2 other assistants were available and helped with paperwork and so forth, Jess Jessen and Ursula Marquis. There were 7 people from investigative agencies, Don Schnichter from the DCI, Gary Oldenburger, the Wapello County Attorney, Michael Siren from the Ottumwa Police Department, Scott Adams, Police Department investigator, and then we had our investigator in our office, Matt Lively, as well as a medical student, or a medical intern, I should say, who was in our office for the summer.
Now, while you conducted this autopsy, was there any other discussion, or pardon, I'll retract that question. How did you proceed in beginning your autopsy of CLOE Chandler?
Well, when a small child dies, we almost invariably do x-rays, and that was done prior to autopsy. And I discussed a bit about what was understood about the case with the investigators who had been in the county, and then proceeded with collection of evidence and documentation of the external findings.
Why are x-rays usually done with a child of that age?
We want to make sure that the skeletal development is normal and check for any kind of fractures or other signs of abnormalities such as growth retardation or metabolic problems. So primarily we're looking for injury, but the x-rays can often tell us other things. For instance, is there lead poisoning and that sort of thing. So we do the x-rays and often have a pediatric radiologist look at them as well.
While you proceeded with this autopsy, what did you do next once the x-rays were concluded?
Well, the external examination, as I said, was begun with evidence collection and documentation of external findings.
And once you completed the external examination, which we'll go through, was there an internal examination?
Yes.
And where did you focus your internal examination?
Well, I focused my examination on each body cavity and the organs therein in turn. I wouldn't say that one organ required more interest than another, although in this case, because there was injury of the neck, the dissection was a little bit more detailed before the organs were removed than sometimes. But the contents of the head, the neck, the thorax, and the abdomen were carefully evaluated both before they were removed and after they were removed, with each organ examined in turn. That being said, the heart was not present because Chloe was a tissue donor, and a cardiac pathologist actually did that examination. And although I saw the brain and spinal cord from the outside, those organs were sent to a specialist as well.
Now, you mentioned that some organs were removed by a separate pathologist. When you initiated your autopsy, did you have their report to inform your history?
No, the organs were not removed by another pathologist. Rather, since Chloe was a heart donor, her heart was removed by individuals trained in that by the Iowa Donor Network. And so they removed the heart and they used the valves for individuals who need a valve transplant, if you will. But the majority of the heart is intact, and that's sent to a cardiac pathologist, a specialist who actually happens to be a forensic pathologist as well. And they evaluated the heart. They're from Minneapolis, and so they look at the heart in detail and then send us their report.
Now, once you've conducted your external examination, your internal examination, can you walk us through some of the findings that you made?
Well, most of Chloe's organs were normal. The lungs had a bit of blood in them from breathing in blood, but otherwise they were not unusual. Her brain was examined by a neuropathologist, and there was evidence of what we call asphyxia, which means that there was not enough oxygen available to the tissues, and so the brain responds to that in a specific way, and those findings were there. There was brain swelling, a little bit of hemorrhage on the outside of the brain. The solid organs, such as the liver and the kidneys and the spleen, etc., were normal.
You noted there was indications of asphyxia. At least, how can that occur generally? What are the when you have a child presenting the way Chloe did? What do you look for once you see signs of asphyxia?
Well, signs of asphyxia are nonspecific. They can occur physically, things like what we call petechiae of the eyes or organs. Those are tiny little pinpoint hemorrhages. Those can also occur from other reasons. So it's sort of like, I tend to use cooking analogies because I like to cook. So if you have an egg An egg may be non-specific. If you make it into an omelet, that's an egg dinner. If you put it in a cookie, it might not appear to be an egg meal, but the egg is part of the making of the cookie. So it's kind of similar. Some of the signs of asphyxia are non-specific, but put together, they can be important in the diagnosis. As far as the brain goes, there are specific things that the neuropathologists can look at under the microscope that are a bit more specific to asphyxia, and those include some changes of individual cells. They become more red, and some special stains are there if there's asphyxia, but not there if there's not. So there are various signs. Swelling of the brain is a sign of asphyxia. Again, it's non-specific. The brain can be swollen for various reasons, but it's something that we see. And then it depends upon why the asphyxia occurred. If there's an injury that limits the oxygen supply of the body, then those injuries are evaluated, and all of the information together is assessed, and ultimately a diagnosis is made, just like with any other doctor who collects the blood work plus the physical exam plus the x-ray findings before making a diagnosis, for instance, of pneumonia. They might hear crackles in the lung or not. They may do an x-ray which would show some cloudiness or not. They may do blood tests, and those blood tests may have findings or not, and together they assess what's relevant, what's not relevant, and make the diagnosis.
As far as CLOE Chandler, once you completed the physical autopsy of CLOE, what was the cause of death physically for CLOE?
Strangulation.
Can you walk us through, when you say strangulation, what it means for forensic pathologists to know that?
Well, strangulation is a broad term. We specifically think of it as having injury caused by something constricting the neck, but it can be due to hanging, a suspension type strangulation with a ligature. It can be due to a ligature strangulation caused by forces other than gravity and body weight, such as pulling or pushing on the neck, often with a tool. It can be manual strangulation, as when someone uses their hands. And then there are other kinds that are even less common, like compression with the arm and the elbow used to make what's often called a chokehold kind of a thing. So strangulation is a broad term, and there can be quite a few different manifestations of that.
Now, what physical evidence of strangulation did you find on CLOE?
Well, first of all, there was a ligature furrow. A furrow is what we call a patterned injury that's on the neck in terms of strangulation, and that reflects the presence of an object that caused constriction of the neck, most often some kind of ligature. That is actually an abrasion, often combined with a contusion, and sometimes just pressure marks. So that ligature mark is one of the signs that may or may not be there. Internally, we look at hemorrhage. which is essentially a bruise. And the bruise can occur at many layers of the neck. Sometimes it's not there at all. A good part of hangings, the hanging desks we see, do not have any injuries in the neck whatsoever. And that has to do with the completeness of the constriction and the location of the ligature. But there may or may not be that injury in the neck. Further in the neck, deeper, are hard structures. The Adam's apple is actually a piece of cartilage. It's shaped like a shield, and it's part of the larynx where the vocal cords are on the inside. That cartilage can be fractured. In older people, it actually turns, at least partially, to bone oftentimes. And that makes it easier to fracture if a person's older. There's also a horseshoe-shaped bone above that Adam's apple area, kind of way under the chin, which is called the hyoid bone. Muscles that control the tongue and the swallowing structures and so forth connect to it. And sometimes that can be fractured. Rarely, even deeper structures can be fractured, like the vertebral column, the spine that lies behind all those laryngeal structures. And also very rarely, sometimes muscles in the back of the neck can be injured. I talked about the fractures. Oftentimes there are no fractures in the front of the neck, but there are layers of muscles there. And those muscles may have injury as well. Sometimes they're very subtle, and sometimes not so subtle. The tongue, I'm sorry.
Your Honor, to help walk through this portion of the testimony, the state is going to wish to present State's Exhibit 52B through 82. I believe there's already been a stipulation on these.
That's correct, Your Honor.
State's Exhibits 52B through 82 are received.
Thank you, Your Honor. Permission to publish.
Permission granted.
Should I continue?
If you'll hold on just a moment. I guess just for the purposes of maybe family members of the jury, we're going to go through pictures of your autopsy. If anybody wants to read, would it be allowable if they ask, raise their hand, maybe? Given the nature of them.
Well, if members of the jury need a break, I would consider that. Those in the gallery can just get up and go.
I want to present you with State's Exhibit 55B. Could you describe what we see here?
This is a diagram of the inside of the neck. Right under the word larynx, there are some muscles, and those are under the tongue. You can feel them if you just press under the tongue. And they connect to the white structure that's horizontal or crosswise in the diagram, which is the hyoid bone. Again, that's the horseshoe-shaped bone. It's open in the back and curved in the front, and the muscles connect to it. On the sides, making a V, one on each side, is a large muscle called the sternocleidomastoid. It refers to the fact that it connects to the sternum, which is the breastbone, the clavicle, which is where that cleido word comes from, and the mastoid process, which is the jaw. That is the big muscle that you can see in an individual when they turn their head, and that you can feel in your own neck quite readily. There's one of those on each side. Next to those muscles and also underneath them are what we call the strap muscles. They're called that because they look like straps. They're belt-like in that they're long, and then they have a relatively shorter width, and they're pretty thin. And they're layered in the neck between either the hyoid bone or the larynx, which is where the voice box is, to the structures around the lower neck, the clavicle, etc.
Now I'd like to show you the next exhibit. And this would be States Exhibit 55C. What do we see here that we didn't see before?
In this exhibit, those large muscles, the sternocleidomastoids, have been removed so that the underlying structures can be seen a little bit better. Underneath them, there are blue structures, and those represent veins, in particular the jugular veins and branches of the jugular vein. There are also smaller muscles. Some of them are cut away, and some are the strap muscles. And again, at the top, you can see the jawline or the mandible with the under the tongue muscles, followed by that hyoid bone peeking out from the middle, just under the area where the black lines are, is the voice box or larynx, where the Adam's apple is. There's a smaller cartilage underneath it, and then below all that is the windpipe or trachea. Also, in the middle there is the thyroid gland. So the muscles are on top mostly, and they are in various layers of the neck. Peeking out next to the jugular veins, up near the jaw, are structures that are a little bit more red. Those are the carotid arteries, and we'll see those in another diagram a bit better.
We'll move on to that diagram. What do we see here in States Exhibit 55D?
Exhibit 55D is also a diagram of the larynx, but the muscles have been taken away. So you see at the top the jawline. Underneath the jaw is the hyoid bone, that horseshoe-shaped bone. In blue is the laryngeal cartilage, or the voice box cartilage. Below that there's a smaller cartilage, and then the rings of the trachea or windpipe. You can see in red the arteries, and the largest ones that are parallel to the voice box are carotid arteries, and also vertebral arteries. Those are well protected deep in the neck so that they are available to take oxygen to the brain. And then in this diagram, the veins have been removed. They're a bit further forward. Behind the larynx is the spine, or the vertebral column. And those are the bones that are in a series, one on top of the other, behind the larynx.
Now, using States Exhibit 55D, would this diagram help you illustrate or point out areas that come into play during the pain or strangulation? Would this particular exhibit help you explain that generally?
Well, yes, it and the other ones help me explain the structures that may be injured.
So, at least using States Exhibit 55D, could you explain to the jury what you would expect to be affected and what you would expect to find in a hanging style death?
Well, hanging deaths usually involve a ligature that often slips above that hyoid bone, at least at some point. The ligature often starts below that level and slips up. Because with a hanging death, the ligature is tightened by gravity or the weight of the head, or both. Constriction of the neck occurs rapidly. So the first thing that happens is those jugular veins become compressed and the blood can't get back out of the head to go to the heart. But also, because the constriction occurs pretty rapidly and pretty completely, because the ligature goes all the way around the neck, or at least partway, usually on both sides in the front. The carotid arteries also get occluded, so blood can't get into or out of the head. Therefore, when adults are hanged and that hanging occurs rapidly, oftentimes their face is pale because blood doesn't get in or out. The ligature, if it's narrow enough, can compress the soft tissues. And again, I like to think of food analogies. If you're making cookies or pie dough and you've rolled out the dough, if you would take a wooden spoon and take the handle and press it into the dough, it would make a furrow, and it would be pretty long and narrow, and it would be relatively easy to press that spoon and make a furrow. If you turn the spoon around so that the flat end is up and you press that into the dough, it may make a furrow, but it's going to be a bit shallower and less easy to see. So it's similar on the neck. If a ligature is very narrow, or if it's patterned like a belt, then that pattern may show up on the neck, and it may be very distinct. And the more narrow the ligature, the more distinct and often deeper that furrow is. If there's movement of the ligature, then that furrow may not be as regular. It may have some irregularities caused by, say, the ligature slipping as gravity causes the ligature to go up and the body to go down. So it varies what we'll see. If a ligature is very soft, like it's padded, for instance, with a towel, or a sheet is used, or some other cloth, then there may not be a ligature furrow on the neck at all, or it may be very minor. So it depends upon the ligature what mark is made. It also depends upon how rapidly the body drops, and it also depends upon the body itself. So ligature furrows can be quite prominent. Inside, there may be some hemorrhage of the muscles. The most common hemorrhage is in those sternocleidomastoid muscles, those big ones. And that makes sense because they're closest to the surface and they're big and they're on either side. So the ligature is likely to cause a bit of a bruise there sometimes. Less frequently, there's hemorrhage of the strap muscles. Sometimes the hyoid bone is broken, and that's because the ligature pushes up. It's more often fractured in adults, and the older the person is, the more likely bones are going to be broken. Very, very rarely fractures will be in children, extremely rarely. The voice box may also break. On the diagram, the cartilage of the larynx is shield-shaped, but it's kind of difficult to see, but in the back, there's a little point that goes up. It's called a cornute or horn. And there's a little horn on either side of that larynx. And because it sticks up like a tiny finger, that can be broken. And sometimes that's broken as well. With hangings, the hyoid is more likely to be broken if anything is. With strangulation, as I'm referring to it meaning ligature or manual strangulation, the hyoid bone is more likely to be fractured. In hangings, however, the most frequent thing we see on the inside is nothing. We see sometimes a bit of compression of the fat where it's squished under the skin, under that ligature, but because hanging occurs in a way that's pretty rapid and circumferential or all the way around or symmetrically, there's often no injury at all. And that's the most common thing that we see with hangings.
You noted hangings tend to be more rapid. Obviously, that's a term that can vary. What do you mean by rapid for this context?
Well, if those carotid arteries are compressed, and they're compressed evenly, loss of consciousness can occur in seconds. With a strangulation type death, a pathologist will say it takes seconds to unconsciousness and minutes to death. So within about 3 to around 10, sometimes 15 seconds, the person who is hanged becomes unconscious, unless there's movement underneath it, like with strangulation where there's a struggle and the hand or the ligature may be released a bit, and then the timing is less specific. But if that hanging occurs rapidly, then loss of consciousness occurs, and then gravity takes over and there's no blood or restricted blood to the head, and death then will occur in minutes. There will be movement of the body that's caused by convulsions or seizures that occur right after unconsciousness. After the seizures, the body has what's called posturing, and that's what neurologists call movements that are not controlled by the thinking part of the brain, but movements that are reflective of the fact that the thinking part of the brain is no longer directing movements. And the movement that occur includes the arms and legs becoming stiff in one kind of posturing called decorticate. The arms tend to curl under. In another kind, they tend to curl forward with the fists turning outward. The legs also have that movement. And that's reflective of the fact that the brain is losing oxygen, it's beginning to die, and those muscles have lost their brain control, their cortical control, but they're just controlled by deeper parts of the nervous system that are more reflexive. So within minutes after the hanging occurs, those movements will occur. Also, the eyes will fixate pretty rapidly. That means that they don't turn from side to side anymore. You can't control them. but they stare straight ahead. The way we learned this is that in the digital age, some people have hanged themselves in suicide and they've recorded themselves on video. And so doctors have been able to look at those videos and see the sequence of events that occurs. So in hanging, there will be loss of consciousness in about 3 to 15 seconds, followed by seizures, where the body moves pretty violently back and forward like any epileptic seizure. After that, there's this posturing that occurs with the muscles that get stiff and move in a particular way. And early on, the eyes fixate, they can't move. Also, then the body goes limp. But some breathing occurs for a while, for about 2 minutes. And eventually the muscles go limp. They'll twitch a while sometimes, but after about 4 minutes, the movement stops. Now, that also depends upon whether the ligature is complete or whether it's partial, because those times will vary depending upon the weight of the person, the type of ligature, etc. But these are general statements about hangings.
Your Honor, given the time, we do expect to get into the specifics now that a lot of the explanation is done. Would it be a good time to take a break now?
We can certainly take our lunch break now. So members of the jury, please remember all the prior admonitions. Keep it in mind. Don't talk to anyone about this case. Whoever you might be having lunch with, do not speak with them about this case. Pay no attention to any media accounts. Do no investigation. We'll see you back in the jury room by 5:01.